Next speaker, a rising star, speaking Felix Gonzalez at Emory University. And for those who weren't here earlier in the session, Felix is, as I mentioned, based at Emory University in Atlanta, Georgia. He is the Assistant Professor of Radiology and Imaging Sciences and Clinical Site Director of the Division of Musculoskeletal Radiology and Image-Guided Medicine at Emory, and a consultant radiology for a number of sports teams in Atlanta. So, Felix, you're going to tell us about something that, from my point of view at least, is a new kid on the block. We heard an earlier presentation by Teppo Järvinen in this session about arthroscopic partial meniscectomy, the rise and fall, if I can use that term, of that intervention for painful knees in middle-aged and older people with degenerative changes of various degrees. So you're going to tell us about radiofrequency ablation and the role of that intervention in treating that sort of patient population. Am I right?
Yes, thank you so much for the introduction, and thank you for the invitation to speak here today. So I guess I can do share screen.
Go ahead. Yep.
Do you all see my slides?
I can, yes, but go into presentation mode, click the little screen down there under apply all. It says there's a little screen at the bottom there. If you click that, you'll get to go into the slideshow mode. There you go. Beautiful.
All right, so thank you so much for the invitation again. This is my first time that I speak to your society, so I'm really excited to be here. So my presentation is, what else is there, clinically speaking, to offer to patients in the setting of moderate to severe osteoarthritis besides the usual cortisone and even a little fancier, right, biologics. So my name is Felix Gonzalez. I'm an assistant professor of radiology at Emory University here in Atlanta. So my objective is to review the controversy that exists right now about corticosteroid injections in large joints, to discuss alternative treatment for arthritic joint pain, such as thermoneurolysis, in this case, specifically radiofrequency ablation, to do a little comparison between cooled RFA and traditional RFA, also to elaborate a little further about how our lab has been able to optimize treatment efficacy using different techniques, 3 versus 4 needle approach. We'll go over that. And to further elaborate other applications that we're using for the shoulder and hip OA treatment. A little background information here. Some literature has recently been published specifically questioning the the setting of corticosteroid injections. Are we actually helping the patients, or are we making the arthritic process progress and get worse? So this is a paper that was published in Skeletal Radiology in October 2018, basically pointing or making some observations about how some of these patients, after the injection, the OA progresses. And this is a typical patient that they spoke of in this paper. So here we have a 58-year-old woman presenting with moderate grade 2 osteoarthritis for 4 months. And after she received a Kenalog 40 milligrams per cc concentration in 4 cc, diluted in 4 cc of ropivacaine, 3 months later, you can see the progressive arthritic disease, right? You have moderate superolateral asymmetric and spaced iron here, and you can see now, just a few months later, 3 months later in this case, she's bone on bone now and still with a lot of pain and discomfort. And this is not only limited to the hip, right? More literature has recently been published and presented to the clinical societies that it's not only limited to the hip, we also see it in the knee as well. This is a case of a 69-year-old patient that received a corticosteroid injection And within 11 months after the treatment, you can see ABM progressing with subchondral insufficiency fracture along the medial knee compartment, specifically the medial femoral condyle. And now he's a bone-on-bone full thickness chondral defect and meniscal tear. This is a landmark paper that I encourage everyone in your society to read. It was published in Radiology, questioning, right, the intraarticular corticosteroid injections in the hip and knee, perhaps not as safe as we thought. It's a fantastic read, and I encourage everyone to go over this paper. So, everyone knows how big of a problem is OA and chronic pain, right? They many times go together. Chronic pain affects at least 100 million Americans. 78% of the patients that suffer from pain, they think that they will suffer of pain for the rest of their lives. Most patients that have chronic pain, you see in the setting of a spinal disease. However, most of those patients, 75% of those patients, also have pain elsewhere, specifically in the knee and hip. And OA affects 30 million people in the US, patients, about 10 million of those present with advanced symptomatic OA. And they usually suffer from chronic pain for at least almost a decade. The problem is that 50 to 80% of those patients are not immediate candidates for surgery. Many times, the way clinicians like myself treat OA pain is by prescribing opioid analogs, right? So there's a big problem in this country of abuse and drug addiction. Just to give you a little data here, between 1996 and 2016, more than 200,000 people die in the U.S. from overdose related to prescription opioids. Prescription opioid drugs contribute to 40% of all U.S. opioid overdose death, right? So our physicians, contributing to the problem. And even though the U.S. only makes about 5% of the world population, we consume approximately 80% of the world's prescription opioid drugs. Huge problem. What kind of clinical treatment algorithm do we have to treat, for example, knee pain in the setting of OA, right? So we have weight loss, NSAIDs, physical therapy, and injections and more injections. Injections that contain lidocaine and steroids that contain viscous supplementation. These patients basically fluctuate from treatment modality for almost a decade. Only a fraction of them, 35% approximately, go on to have surgery, but 65% of them never had surgery. So there's a gap between, clinically speaking, between those modalities that give short-term pain relief, right? The supplement, corticosteroid injection, the viscous supplementation injections only give pain relief in terms of month, right? And the pain, in most cases, the pain comes back. I'm talking about this in the setting of moderate to severe arthritic pain, and without having surgery, which is the modality or the treatment option that induces long-term pain relief. So there's a big gap here between short-term and long-term treatment options. One way to treat the new way, right, that has been introduced recently, is to disrupt the transmission of pain signals through neurolysis coming from the knee to the brain. And there's two ways that we can do that clinically. There's a thermal option, what we call thermal ablation, that comes in two different flavors. We can do a standard radiofrequency ablation and cooled radiofrequency ablation. I will speak about that, the difference between those two modalities. And cryoablation. Cryoablation is actually the opposite. With cryoablation, you freeze the tissue, disrupting the cell membranes and interrupt metabolism. Here today, we are going to talk about the thermal ablation options. There are two different options that we have in that category. We have the standard radiofrequency ablation, the cool radiofrequency ablation. The main difference between those two is that usually the temperature achieved with radiofrequency ablation gets up to 80, 90 degrees Celsius when we're treating a specific area. With cool radiofrequency ablation, the temperature usually raises to 60 degrees, so it's a little lower. The main difference is in the area of treatment. With cool radiofrequency ablation, we are able to achieve 5 times larger lesion than with standard radiofrequency ablation. And you may ask yourself, well, how is that clinically relevant? For example, in the setting of treating knee arthritic pain. Well, Here's a study that shows 15 cadaveric dissections where they actually trace the anatomic course of each of the genicular nerves surrounding the knee, and you can see how much variability there is, right? This is in terms of centimeters. So one patient, this nerve, for example, traversed the physical space a little more posteriorly, but in another patient, the same nerve, was a little more anteriorly translated. So you have to be able to account for that variation that exists between patient and patient, patient to patient. In the setting of the knee, we have four traditional sites that we usually treat. So 1, 2, 3, and 4. These are the genicular nerves, the main genicular nerves around the knee. Traditionally, physicians have only treated location 1, 2, and 3. In our study, we added an extra needle here, superior to the patella, approximately 3 centimeters. And the reason for that is because most patients that I see clinically in my clinic that present with knee OA presents with anterior patellofemoral compartment pain. This is a very nice study that I've been trying to do for some time now, but without without having extra help, it's kind of difficult to do. But this is a nice study where they actually map the genicular nerve utilizing MRI, and if you basically use the junction or the way where the codices meet, if you trace a line along the superior cortex here, or the femur, and if you trace another line along the epicondylar region, where those lines intercept, if you use that as a way to guide yourself using X-ray and fluoroscopy, that's the main modality that we use when we treat these patients. We don't use MRI, we use X-ray. If you use that junction there, you're going to be 88 to 100% accurate in targeting those respective nerves. So what we did, we basically looked at the safety and efficacy, utilizing cool radiofrequency ablation for the treatment of patients with moderate to severe OA. And this was a single institution experience here at Emory. This is a published paper that was recently published. So our study design, we included 50 patients with a total of 77 knees. Our inclusion criteria included patients older than 45 years of age, with moderate to severe OA, refractory to anti-inflammatory analgesia, and that failed multiple intraarticular lidocaine and steroid injections. These patients were referred to us by our orthopedic colleagues, orthopedic surgeons. Every single patient received a standard knee radiograph to grade the degree of arthritis. The way we do this is we bring the patient on day one and we do a nerve block with lidocaine. So we place the needles in those respective locations. We inject about 1 cc in each of those locations, and then the patients go back to the wetting area, to the observation unit, and there each patient gets assessed within 15 to 20 minutes. And what we're looking for is we have a baseline pain, and then what we're looking for is at least 50% pain reduction. In our study, if the patient had at least 50% pain reduction, we basically progress to the ablation phase. So the ablation phase, or the second part of the procedure, included either 4 needles, as an example here. So the needles are placed in those respective locations, femocondyle, medial lateral, and then superior to the patella 3 centimeters, and inframedial tibial. And then on the lateral side, we want at least that needle to be 50% of the anterior to posterior width of the bone. That's a 4-needle approach. This is a 3-needle approach. The way we do this clinically is we give conscious sedation with Versurf and fentanyl. We numb the skin first, and then we introduce an introducer that varies in length, 50 to 150 milliliters, 15 centimeters. And then once the introducer is in place through there, we introduce an electrode probe that has a 4 millimeters active tip. So that very distal portion of the needle exposes itself. Before we actually do the ablation, we check for motor activity utilizing a specific protocol. And once we prove that we're not anywhere near a motor nerve, we inject 1 cc of 2% lidocaine, and then we proceed with the ablation. The ablation takes about 2.5 minutes. at a set temperature of 60 degrees. So we basically treat 4 different sites or 3 different sites utilizing this protocol. And then we basically follow patients different respective times, 2 weeks all the way up to 6 months, utilizing well-established and validated clinical surveys, the WOMAC and KOOS, at the respective time specified here, up to 6 months. So just to recap here, the patients came in for an anesthetic nerve blocks. They received at least 50% pain reduction. We took into the on a different day, usually within 4 weeks. We had them. We basically did cool leaf or cool radiofrequency ablation on them, and then we followed them up to 6 months with a phone call, basically going over the questions for WOMAC and KOOS surveys. So our subject demographics, we had 74 female and 26% male. Most of them were African American, probably reflecting the local population here in Atlanta. We asked him how many injections of cortisone and lidocaine they have in the last year prior to the procedure. And you can see here, most of them had at least 1 or 2. Most of them had 2 or more. We asked him how much pain they had prior to, how long did they have pain for prior to the procedure. And it varies between 2 and 3 years. So how do we do? So out of all the patients, 82% initially received pain relief, and the pain relief was at least by 50%. And then all the way up to 6 months, where we stay in the realm of 79 to 82%. We also, something very peculiar that we found was clinically, right? So we started to do these procedures. The patients only from the first part of the procedure, the nerve block, we asked them how long did that nerve block lasted, and they reported between 2.5 to 3.3 weeks. Something that I still about having able to find a specific solution answer to this question. I asked different surgeons and neurosurgeons, and we don't know how lidocaine that only lasts for 3 or 4 hours gives pain relief up to 3.5 weeks. We looked at the VAS score. The baseline score was 8.4, which decreased to 3.3 overall in the end at 6 months. So this is 2 surveys here, data, KOOS and WOMAC to the right and KOOS to the left. I purposely inverted the WOMAC scores. Yeah, I know that it should decrease, not increase, but I inverted them just to show, to be able for you to be able to compare it to the KOOS score. We'll utilize a formula that has been validated in our paper. Is the formula is there as well. So just to know that the WOMAC scores has been inverted for your, for the ease of looking at comparing the KOOS versus WOMAC. Here we have baseline, 3 groups, baseline, 3 and 4 needle groups, and you can see how there's drastic differences in improvement of function. These are all the subscores, basically function, pain, quality of life. Not significant differences between 3 and 4. Slightly better for the 4 needle group, and those results were reproducible on the WOMAC score as well. This is a 1 month. That was at 2 weeks. This is a 1 month. The same information and trend of data here. You can see drastic improvement with a slightly better, results with the 4 needle. Still not significant difference between 3 and 4. However, at 3 months now, you can see more pronounced differences in favor of the 4 needle group. Again, they still have persistent pain relief compared to baseline, both with KOOS and WOMAC as well. And at 6 months, we saw the same trend, slightly better for the 4 needle versus 3 needle, KOOS and WOMAC equivalents. We also asked him how many opioid medication they were taking before and after. The way that you do this clinically, and it's a more, the purest way to do it, is you count the number of pills per day that they take. Unfortunately, my resources for the study was limited, so what we did, we asked him how many medications they were taking before, how many medications they were taking after a 6 month of the procedure, and we saw 65% decrease in the usage of those opioid medications, and the 4 needle group was the predominant group where we saw that difference, that change. So overall, our follow-up time was 6.1 months. we saw significant pain relief and decrease in stiffness and increase in the functional daily living among these patients. Just a little review of the literature. We have different studies that have been published over time since 2015, utilizing cool frequency ablation to treat knee OA. Most of these studies have utilized patients with moderate to severe OA that don't qualify for surgery, so there's nothing else that they can do to treat their knee pains. And on the second, I know this is a little busy here, but what I wanted to illustrate is that most of these studies report pain relief 6 months first, and then a 12-month as well, with a little less frequency. And then one study reported benefit at 24 months, this study here. So we usually, in the clinic, we usually tell patients that, pain relief has been demonstrated between 6 and 12 months. So where are we going from here now? We are actually exploring the possibility, or we actually released a paper in the most recent RSNA meeting. This is a radiology meeting on 23 patients with shoulder OA, targeting the respective nerves, suprascapular, axillary posteriorly, and then anteriorly we targeted the lateral pectoral nerve. And we saw very, very, very good results. So we're going to expand on that. This is the different nerves here. It's a schematic showing the suprascapular nerve, and my needle here treating one patient. This is for the axillary nerve, and this is for the lateral pectoral nerve. And we also did a similar study on hip OA, targeting the anterior nerves, specifically the sensory nerve of the femoral branch here, and the sensory nerve of the actual nerve. And here you can see the respective location of treatment. So with that, I end my presentation. Again, thank you so much for allowing me to speak to you today. And if you have any questions.
Thank you very much, Felix. That was a very interesting presentation, and I learned a lot. My knowledge of this particular intervention has been rather scanty. Can you, just as a beginning, tell us in what other possible areas this technique is being used? You mentioned brain earlier on.
Brain?
Didn't you? Yeah. Didn't you mention that this technology had been used in brain surgery or something like that?
Yeah,
Or am I wrong?
misspoke. Yeah, I misspoke if I say that. So usually, the area that we have been treating, that we have been using this analogy on, is for the treatment of arthritic pain, especially in the moderate to severe setting. The other areas that we are exploring this modality is in the treatment of metastatic disease. So patients that have metastatic lesions in large joints that cannot have any other intervention, and either terminal or with severe pain, we have a few patients that we have utilized the technology on with great results. The other area of treatment as well is in the setting of sickle cell anemia or sickle cell crisis, where you have bone infarcts, and with excruciating pain. There's nothing you can do. If you inject lidocaine and cortisone, that has been very well demonstrated in the literature that leads to increased joint infections. Actually, a lot of these patients are already seated with salmonella, so you definitely don't want to inject any cortisone in there. We have used it in that setting as well. I think the oncologic applications are huge and very well received and perceived here by our colleagues in our hospital.
I have another question that's connected to a question that came in through the chat here, and that's what would be considered a placebo for testing this technique. And I'm a bit of an evidence nerd myself, so my first reaction would be, where's the double-blind randomized controlled trial to show the effect of this particular, or the specific effect of this procedure as different from the possible context and placebo effects?
I mean, that's a really good point, and something that I wanted to do with this study, but unfortunately, it's kind of hard to I guess, because the procedure, this procedure is somewhat complex in the setting that it has two different steps. It has a nerve block first, and then followed by an ablation procedure. So with the nerve block, we proved that there's an immediate pain relief, right? The patient, and these patients come in with excruciating pain. They are like 8 out of 10, 10 out of 10. I mean, these are patients that you do a subdermal injection and they're screaming their lungs out and on the operating table. These are not the usual, mild and low grade pain. These are very high grade pain patients. So in that setting, it will be difficult to prove a placebo effect. I think it'll probably be in the ablation phase where we will do, no ablation or ablation and see how they respond. But it
The
will be difficult, I guess, to do in the nerve block phase.
Yeah, the kind of perfect, or theoretically at least perfect placebo study would be, you introduce the needles, but you don't flip the switch on the current to
Exactly.
do the ablation.
Yep.
But yeah, there are many other questions coming up here. I have one question from Kale Jacobs, and he's asking, in your clinical experience, what percent of patients respond to the initial nerve block versus the percent that do not report more than 50% reduction with a block?
That's an excellent question, and I'm glad that someone asked that question. So everything has to do with how you select your patients, right? What's the who are your patients that will benefit from this procedure? So I had the benefit that my patients come from an orthopedic surgeon who is very experienced in doing knee arthroplasty. So he knows exactly the patients that will benefit from the procedure. I have treated a little over almost 3,000 patients already in the last 2.5 years. That's how much of a need there is for something like this. I only had 2 patients that did not respond to the nerve block. Now, someone may say, well, you're definitely biased. There's something biased there because how is that even possible? Well, these are patients that have been filtered, right? This is filter over upper filter. These are patients that have moderate to severe OA that tried multiple cortisone injections. And by the way, the cortisone injections, the typical response that I hear, they always say, well, the first injection, it gave me a year of pain relief. The second one, 6 months. The third one, 3 months. The last one, the fourth one, no pain relief at all. So that's like that. I can almost record, that and have it played in other to the patients. So this is a patient that have exhausted every possible treatment option and don't qualify for surgery. So I only had 2 patients that did not respond and they actually had metastatic disease. One had a metastatic lesion, the other one had a primary bone tumor.
I have a question, or rather Teppo has a question, Teppo Järvenen, who the previous speaker in this session. So please go ahead, Teppo.
Thank you for a very interesting talk. While listening to your talk, I was going through some of my slides, and I don't know whether I'm going to be able to share my screen, but let's try. No, I'm not able to share.
Okay,
but if you,
I can stop sharing.
Okay. If you stop sharing, yeah, that should be possible now.
Okay, let's see if
give it a try, or we can ask.
No, but if you click the link that I put in the chat,
if you try, you should be able to share.
Okay, let's try one more time. Now I'm actually able to share. So let's see. Do you share? Do you see the picture that I'm showing right now? So this is actually of denervation, nerve ablation that was done to treat renal or hypertension. And just the sequence of events that took place, and we are talking about hypertension, so one would believe that there is little you can kind of externally manipulate your blood pressure with. But just to show that this was an interesting theory, and when patients were this was just the technique was applied to patients who were not non-randomized, and doctor knew of the allocation, and the patient was unblinded. This was the effect on hypertension or blood pressure. And once you go through these different phases, you will see what happens to the effect. So as as an orthopedic surgeon, seeing these patients, for me, a patient that screams on a table when I'm trying to examine or do something with a needle and the patient screams, that is a call for, I take off, basically. I think it sounds very alarming to do anything for a patient that is that sensitive to pain. We are talking about OA, at least in the 15 years that I practiced orthopedics. I don't do surgeries anymore. But when I did, whenever I had a patient who screamed for pain, that was on. I had all the alarm bells and whistles blowing, because I didn't want to touch the patient who is that painful. With all due respect, this is a very interesting. It sounds like a very interesting stuff. It's a very bioplausible theory, but I do have to say, with all due respect, that this needs to be before this this is an experimental procedure, and it needs to be studied in a placebo-controlled design, just like Stefan said, before anyone can promote this to for wider use.
Teppo recently, an hour ago or so, told us really sort of an educational story about the rise and fall of arthroscopic surgery, with, again, a very, very plausible theory behind it for having an effect and being connected to, etc. And I think that should be sort of a story that we should keep in the back of our minds whenever we start looking at new technologies to treat our patients. We're having a question from, or a comment from, Neil Siegel. And Neil, why don't you unmute yourself and ask the question?
Sure. Thank you for your presentation. I had a question. So cryoneurolysis, where we use a cryoprobe to induce a reversible conduction block in these same nerves around the knee, has been around for a while and has been shown in randomized double-blind placebo-controlled trials to have a pretty good effect on analgesia. I was wondering if you know of any data that compares the RFA results with the results for cryoneurolysis for knee pain or the other joints you mentioned.
That's actually an excellent question. So I have a colleague here by the name of David Prologo. I don't know if that name resonates to you or means anything to you. But David Prologo is probably one of the most recognized physicians out there using cryoneurolysis to treat not only knee pain but multiple body part pains. So he's actually doing that right now, and there's not, we haven't we submitted the IRB to do a head-to-head randomized blinded control study, but it seems to me that the cryoneurolysis results in the pain relief is shorter. So 3 month, 4 month or so, where the cool reflex ablation lasts a little longer than that. And by the way, I meant to say, I really I thank you for the previous comment. Just want to say that this technology is actually FDA approved. This is not even experimental anymore. If you Google, it's under the commercial name of CoolLeaf. If you Google this, it's widespread throughout the U.S. We picked it up here at Emory, and I basically pushing it for the shoulder and hip. But this is FDA approved. This is something that is being used everywhere. A lot of the patients. It's not only here at Emory. It's just, it's not as popular as perhaps it should be, but it's widely used right now.
Thanks, Felix. I see a question from, or a comment from David Felson. David, would you like to unmute yourself and comment on the two controlled trials that you were mentioning?
So there's two randomized trials of radiofrequency ablation. One is in the journal Pain, published in 2011, and it was a randomized trial with sham It was exactly the way Stefan described what the design should be, which is they put needles in the same places and just didn't do the cooled frequency ablation, and that showed a substantial effect of treatment, highly significant. And the other is a trial comparing radiofrequency ablation to intra-articular steroid injections and showing a far more durable and impressive effect with radiofrequency ablation. And that's in, I'll tell you where that is, give me a minute. Yeah, there are two papers, one a short-term result and the other a long-term result. Not in journals that I read every day. One is called Regional Anesthesia and Pain Medicine and published in 2018, but reasonable design. Yeah, I mean, I think it's a legitimate treatment. My concern actually about this treatment is if you ablate pain excessively, and it may be that this treatment does that you might cause problems with joint damage, the same way we've presumably seen with anti-NGF therapies.
Yeah.
And I don't know whether anti-NGF therapies.
I was thinking of exactly the same.
Yeah, so that's a common question that I encounter in multiple society meetings and presentations on this topic. So the concept of neuropathic joint, right? Charcot joint disease, where you have osteonecrosis and collapse. So out of the patient that I researched the literature on cooled radiofrequency ablation extensively. There hasn't been a single study yet demonstrating that. There's actually a study from England, I believe, that where they follow a lot more patients than we did, and they didn't see a single patient that developed that. Out of the patients that we follow, we got X-rays, standing X-rays before and after treatment at 6 months, and none of them have, again, this is moderate to severe OA, so it's almost bone on bone or near bone on bone and bone on bone, so grade 3, grade 4. None of them had, osteonecrosis or AVM or an infection or, our complication rate was basically, I had one patient that had chlorhexidine allergy, but nothing, no hematoma, no infection, not a single complication like that. And I didn't observe any neuropathic joint in the patient that we treated, and it hasn't been reported in the literature at least yet.
Well,
So
I
Felix,
think we got to be nervous about the fact,
David, I do get really nervous when someone, I have treated, actually, I've used this technology to treat patients with ACL repair, young patients, right? And I get really nervous about this, very nervous. And the only reason why I have done those is because I had one a patient that had 7 ACL revisions, or retreatment. She had so much scar tissue, the pain was unbelievably high. And I said to the surgeon, I will do this only if you do very close follow-up. And she had to be very strict about her protocol afterwards, about weight bearing and return to high intensity physical activity. And that she did really well, post-procedural. But I get very nervous when patients come in with little mild and moderate weight and they want this procedure. I usually back off and say no. Go on and get your gel injection, your PT, your lifestyle modification, lose weight, whatever the case might be. But this is something that I'm reserving for moderate to severe OA patients at the end of that roadway that have no other options. They cannot have surgery because they have comorbidities. The surgeon don't want to, do surgery on them. And then they succumb to addiction to opioid, obesity, metabolic syndrome, anxiety, depression, you name it. So I'm reserving that last resource. That's my patient population. That's where I live.
Felix, it obviously, or it appears to have a dramatic effect on pain. Have you monitored, or has someone else monitored the function in these individuals following the intervention as compared to other? I'd be interested to know what the response is as compared to the pain response.
Very, very good question. So I've seen drastic decrease in stiffness, an increase in range of motion, as well. Having, with the range of motion, I'm doing another follow-up study now where specifically we're going to measure the exact, range of motion changes that happen before and after extension and inflection. But I seen significant decrease in stiffness, increased mobility. Something else that I also seen too is I done ultrasound in these patients, and it seems, at least for what I've seen, is like the joint effusions are less frequent or decrease in size. So those joint effusions are probably sympathetic, right, induced for the pain that and the inflammation that exists in the synovium. And all those areas are the drastic changes. We are embarking on a new study with my colleague here at Emory, David Ryder, and we're looking at actually enzymatic composition of the joint fluid before and after Cooley reflex ablation. We're going to measure the metabolic. We're going to detect metabolic markers in the knees and see what happens over time before and after this treatment. That's a very exciting, research that we're undertaking right now.